Hello. So we are on to chapter 12, Drugs for the Treatment of Cardiovascular Disease. So this chapter is very important. Not only do we have our patients that are in clinic that are mostly, or the majority of our patients are geriatric. So with that in mind, we definitely need to know everything we can learn about cardiovascular disease and the medications that they may be taking. So I have updated this chapter from the 8th edition to the 9th edition. So this is the 9th edition lecture. I did find that mostly the only problem that was with them is like the previous chapters, they may be out of order. So the chapters have been shuffled. The only new slide that I found, you can see on page 158 in your 9th edition pharmacology textbook, is the two medications, the prasugrel and the ticagrelor. Say that. But anyway, those are at the end of the slide, and I plan to, you will see that I've updated that as well. So anyway, this is a long chapter. Take your time, break it up into sections, and let yourself absorb the information. Here are your learning objectives for the cardiovascular agents. So the cardiovascular disease, of course, that's what we're focusing on. It refers to diseases of the heart and blood vessels. This includes hypertension, angina pectoris, coronary artery disease, cerebral vascular accidents, and congestive heart failure. Even though cardiovascular diseases are a leading cause of death in the United States, patients with cardiovascular disease are now living longer, more productive lives, and they comprise a large proportion of the dental patient population. Should wait 6 months before receiving any type of oral health care. So this gives the heart a chance to heal before bacteria from the mouth is introduced into the bloodstream and travels to an already weakened heart. Cardiovascular conditions that are absolute contraindications to dental treatment, such as uncontrolled or severe cardiovascular diseases, should be delayed until a consultation with the patient's provider has determined which special treatment alterations are to be included. Some examples include very high blood pressure and uncontrolled arrhythmias. Again, this is just one other reason to obtain a thorough health history. And for the test, you need to know how to define the myocardial infarction as an injury or necrosis of the heart muscle. I'm sure you already knew that. So according to the clinic manual, which you should be referring to before you come and ask an instructor for some help, unless it's an emergency. So you should already be looking through your manual before your patient even shows up for their appointment. Hopefully you're doing so. So in the manual, ASA for patient, this is a patient we cannot treat in the clinic. The patient has an incapacitating disease that is a constant threat to life. The patient in this category has a medical problem that is of greater significance than the planned dental treatment. So whenever possible, elective dental treatment should be postponed until such time as the patient's medical condition has improved to at least an ASA 3. This patient presents a significant risk during treatment. So some examples of conditions of an ASA4 patient are unstable angina pectoris. As you know, this is a pre-infarction angina, and a myocardial infarction in the last 6 months. Now, this has been updated in our clinic manual to include if the cardiologist or the primary physician requires treatment in our clinic for the patient or is supporting an SRD or a cleaning for a patient, we have to have that on a letterhead And with their recommendations and they're allowing it, it has to be on file before your patient comes in. So don't wait up until the day they come in and then they tell you that they didn't bring the letter. So you don't want to do that because we will not be able to see them. So we want to also make sure the blood pressure, a blood pressure of greater than 200 systole and 115 diastole, severe congestive heart failure or COPD that requires oxygen supplementation or wheelchair confinement, a cardiovascular accident, so a stroke within the last 6 months, uncontrolled epilepsy and uncontrolled diabetes with a history of hospitalization. So also patients currently undergoing cancer treatment or preparing to undergo cancer treatment. And in general, the ASA4 patient will experience distress while at rest. So the majority of cardiovascular patients should benefit from the use of epinephrine in the local anesthetic agent. The amount and effect of epinephrine administered must be weighed against the fact that discomfort can cause the release of endogenous epinephrine. I said this in a previous lecture. So limiting the dose of epinephrine to the cardiac dose, which is 0.04, you should know that, may be warranted in a few severely affected patients. Using a slow rate of injection and appropriate aspiration techniques to avoid intravascular injection reduces the chance of vasoconstrictor adverse reactions. Okay, so here we go. You need to highlight this. Studies both support and reject the relationship between periodontal disease and cardiovascular disease. So it is very important that patients maintain optimal oral health care, which includes receiving dental care, brushing teeth a minimum of twice a day, and regularly flossing teeth and making sure that dentures are fitting properly. Hypertension is the most common cardiovascular disease that affects some 70 million Americans, and approximately half of the people with hypertension are properly treated. Normal blood pressure is defined as a systolic pressure of less than 130 millimeters of mercury and a diastolic pressure of less than 80. High blood pressure occurs without regard to stress or tension. Complications of hypertension affect organs such as the heart, kidney, brain, and retina. These complications are greatly increased with concomitant smoking. Fortunately, early detection and treatment reduces the possibility of damage to vital organs and extends the patient's lifetime. So you should have learned this probably your first semester, but another name for hypertension is the silent killer. So it's because people don't know they have it. They walk around with high blood pressure, or they know about it, but they think they can ignore it, which we see that all the time, where they think they know better than what their doctors tell them. And unfortunately, the damage is being done. But we'll continue. So hypertension is divided into categories based on the cause or progression of the disease. You need to know the cause is unknown for essential or idiopathic primary hypertension and tends to be familial and may be the result of the interaction between environmental and genetic factors. Essential hypertension is divided into stages depending on the severity of the elevation of the blood pressure. These are prehypertension, hypertension stage 1, and hypertension stage 2. You need to know that. Secondary hypertension has a cause that can be identified and associated to a disease process of the endocrine or renal systems. Drug therapy such as steroids, non-steroidal anti-inflammatory drugs, birth control pills, decongestants, and tricyclic antidepressants can also produce secondary hypertension. Malignant hypertension includes those with high or rapidly rising blood pressure. There is usually evidence of retinal and renal damage. So lifestyle modifications are the mainstay of prehypertension therapy and for both stage 1 and stage 2 hypertension. Lifestyle modifications include weight reduction, aerobic physical activity, a diet rich in fruits, vegetables, and a low-fat dairy product with reduced content of saturated and total fats, dietary sodium restrictions, and moderate alcohol consumption and smoking cessation. The choice of antihypertensive therapy is based on the stage of hypertension and the presence or absence of compelling indications. If compelling indications are present, the compelling indications must be treated and other antihypertensive drugs can then be added as needed. The three major types of diuretics are thiazides. They end with the like. They're loop and potassium sparing. Hydrochlorothiazide is the most commonly used thiazide. You'll see that a lot in clinic with your patients taking that. Loop diuretics are considered strong cousins of the thiazides. Furosemide or Lasix is the most commonly used loop diuretic. Potassium-sparing diuretics all have weak diuretic action. Spirolactone or aldactone and triamcinolone or diurenicum are two examples. So the exact mechanism by which thiazide diuretics lower blood pressure has not been determined. The thiazides initially inhibit sodium reabsorption from the distal convoluted tubule and part of the ascending loop of Henle of the kidney. Water and chloride ions passively accompany the sodium, producing diureses. Potassium excretion is also increased. The thiazide's effect on blood pressure may occur because the extracellular fluid volume is reduced, and even when the volume reduction returns to normal, the interstitial volume may remain reduced. Thiazides may contribute their effectiveness to changes in sodium and calcium concentrations or reduce sensitivity to the sympathetic nervous system. So common adverse reactions include hypokalemia. So that's hypokalemia, secondary to sodium-potassium exchange, and hyperuricemia, which inhibits uric acid secretion. Eating bananas when taking thiazide diuretics will help to replenish potassium. Hyperglycemia, hyperlipidemia, hypercalcemia, and anorexia are other side effects. Hyperuricemia is of special concern if the patient has gout. In the patient with diabetes, hyperglycemia must be managed by diet or insulin alterations. The most common oral adverse reaction is, of course, xerostomia. Okay, people who are taking the thiazide diuretics need to be very careful. Non-steroidal anti-inflammatory drugs, the NSAIDs, can reduce the antihypertensive effects of the thiazide diuretics. Most important drug, that is the most important dental drug interaction with the thiazide diuretics. So thiazides can cause hypokalemia and can sensitize the myocardium to developing arrhythmias. The potential for arrhythmias is exacerbated in patients taking digoxin, especially if digitalis toxicity is present. Epinephrine also has arrhythmic potential, limit to cardiac dose when patients taking thiazide diuretics, and digitalis toxicity may be present. The thiazide diuretics potentiate the action of other antihypertensives, increasing the potential for hypotension. Furosemide acts on the ascending limb of the loop of Henle and has some effect on the distal tubule. Like thiazides, loop diuretics inhibit the reabsorption of sodium with concurrent loss of fluids. Loop diuretics can be used when rapid diuresis is required. Furosemide's side effects are similar to those of thiazides and include hypokalemia and hypouricemia. However, there is a higher risk of adverse reactions with furosemide because it is much more potent than the thiazide diuretics. NSAIDs can interfere with furosemide hypertensive action. So you need to see what is in bold here. The furosemide, the Lasix, acts on the ascending limb of the loop of the Henle and has some effect on the distal tubule. You're going to see something about that on the test. So the potassium-sparing diuretics act as different sites in the kidney than do the thiazide diuretics. Spirolactone is chemically similar to the aldosterone, but competitively antagonizes the action of aldosterone. The result is sodium excretion through diuresis and loss of fluid volume. However, the potassium ion is conserved because some of the potassium is reabsorbed at the expense of sodium in the sodium-potassium exchange system in the distal tubule. Although the potassium salts are not cardiac drugs, lack of potassium caused by diuretics must be managed, often with potassium supplementation. Potassium is involved in many important physiologic processes such as nerve impulses, contraction of smooth cardiac and skeletal muscles, and maintenance of normal renal function. It is indicated in the treatment of hypokalemia produced by diuretics. ACE inhibitors should not be given to persons taking potassium supplements because hyperkalemia can occur. Potassium is relatively contraindicated in patients with severe renal impairment or those receiving potassium-sparing diuretics. The most common adverse reaction relates to the GI tract and includes nausea and abdominal discomfort. Patients taking potassium supplements should be questioned about their use of diuretics, and the possibility of cardiovascular disease should be explored when a drug history is taken. Angiotensin converting enzyme, the ACE inhibitors. They help relax the veins and arteries to lower blood pressure. ACE inhibitors prevent an enzyme in your body from producing angiotensin II. This is a substance that narrows your blood vessels. This narrowing can cause high blood pressure and force your heart to work harder. Angiotensin II also releases hormones that raise your blood pressure. So ACE inhibitors can cause hyperkalemia, therefore potassium supplements and potassium-sparing diuretics should not be used with these drugs. Allergic-like reactions can include angioedema and/or a rash. If airway obstruction is severe, it can impair breathing or swallowing, and then it could be fatal. ACE inhibitors should not be given to women who could be pregnant or become pregnant because there is a risk of teratogenicity. Rarely, pancreatitis with symptoms of abdominal pain and abdominal distension have occurred. Proteinuria is more common in patients taking higher doses or who have renal impairment. Dysgeusia is an altered sense of taste, is most commonly reported in patients taking captopril. It is reversible after a few months, even with continued therapy. Autoimmune oral lesions such as lichenoid or pemphigoid reactions may produce oral manifestations. Another thing you need to know, ACE inhibitors often end in pril, P-R-I-L. That would be a suffix. So the effectiveness of ACE inhibitors is reduced by administration of the NSAIDs, so Advil. A few doses of NSAIDs are of little concern, but chronic administration for several days might result in an increase in the patient's blood pressure. The ARBs act by attaching to the angiotensin II receptor and blocking the effect of angiotensin IIs. As with ACE inhibitors, it is less effective in Black patients and other patients with low renin activity unless combined with a diuretic or calcium channel blocker. Because ARBs work by blocking angiotensin II at its receptor, They are more specific than ACE inhibitors and may be expected to have fewer adverse reactions. The central nervous system effects can include dizziness, fatigue, insomnia, and headache. Losartan or Clozar can produce diarrhea, muscle cramps, and leg and back pain. It is also teratogenic. Rarely does angioedema occur, and like the ACE inhibitors, NSAIDs may antagonize the antihypertensive effect of losartan. Okay, so next, I would like for you to understand a little bit more what the differences are between the ACE inhibitors and the ARBs. And so I'm going to actually insert a video clip from YouTube, and it is from a channel that was created for registered nurse or RNs for their education. It is the Registered Nurse RN YouTube channel. So anyway, this presenter, her name's Sarah, and she's interesting and fascinating to listen to, and she'll bring it to life for you. So hope you enjoy.
RN.com, and today we're going to compare some medications. We're going to look at ACE inhibitors and ARBs. And as always, whenever you get done watching this YouTube video, you can access the free quizzes that will test you on these two medications. So let's get started. In our previous lectures, we went in depth over ACE inhibitors and ARBs. But now let's do a quick review so we can see the similarities and the differences. So when you take an exam, you can easily differentiate between these two medications. So we have ACE inhibitors. ACE stands for angiotensin converting enzyme. ARB stands for angiotensin II receptor blockers. Now these medications affect RAS. They do it in different ways, however, they both achieve the same results. Now, what is RAS? Well, RAS is the renin-angiotensin-aldosterone system. But what does this system do? Well, it manages our blood pressure, specifically whenever it drops. And the whole goal of RAS is to get angiotensin II on board because it is a major active vasoconstrictor. And if we can vasoconstrict, among other things, we can increase our blood pressure. We increase blood pressure, we maintain tissue perfusion. So what happens with RAS is that whenever the blood pressure drops, the kidneys, some cells in the kidneys will sense this and they will release renin. When renin goes into the circulation, it is going to stimulate a substance that is in the liver called angiotensinogen. And angiotensinogen is going to turn into angiotensin 1. Well, we got to get to angiotensin 2. So to do that, ACE will help us out. That is angiotensin converting enzyme. It's going to convert angiotensin 1 into angiotensin 2. So we're there. We have this major vasoconstrictor present, but it has to bind to some receptors because then we can get things going. So one type of receptor that this angiotensin 2 is going to bind to is called an angiotensin 2 receptor site type 1. And whenever angiotensin 2 binds with those type 1 receptors, it is going to lead to the results we need. It's going to cause vasoconstriction of our smooth vessels. So when we constrict vessels, that is going to clamp down, and that is going to help increase blood pressure, increase our systemic vascular resistance. In addition, we are going to trigger the release of a substance called aldosterone by the adrenal cortex. And the whole reason for this is to help increase blood volume. Because if we can increase blood volume, we constrict our vessels, we are definitely going to increase blood pressure and maintain tissue perfusion. And to do this aldosterone will cause the kidneys to keep sodium in water but excrete potassium. Now let's look at how these two medications affect RAS, because remember, they do it in different ways, but they achieve the same results. And really what they're targeting is this angiotensin 2. So let's look at ACE inhibitors. What ACE inhibitors are going to do is they are going to inhibit ACE, hence their name. So they inhibit this part of RAS. They prevent angiotensin 1 from turning into angiotensin 2. So we don't have angiotensin 2 being able to do its job. Now, ARBs, what it's going to do is it's going to inactivate the angiotensin II receptor sites type 1. So we will have the conversion of angiotensin 1 to angiotensin 2. You have ACE doing its job. But what we're going to prevent is this angiotensin 2 being able to bind with these type 1 receptors. So you don't get the effects of angiotensin 2. So as you can see, they're both affecting angiotensin 2. ACE inhibitors is just preventing this ACE. ARBs, it's preventing the activation of these receptor sites. Either way, they are affecting how angiotensin 2 works. Therefore, with both of these medications, what they're going to achieve is that they're going to cause vasodilation instead of vasoconstriction. So that's going to decrease systemic vascular resistance and decrease the blood pressure. And it's going to make it a little bit easier on the heart to pump. And here in a moment, when we talk about what these drugs are used for, you'll see why they're beneficial on some patients. In addition, they're both going to decrease that secretion of aldosterone, which again was to help increase our blood volume. So instead of keeping sodium and water, we're going to excrete it, but they will cause the kidneys to keep potassium. So we really have to watch out for hyperkalemia in these patients who take these drugs. Now, some other things you want to remember to help you differentiate between them is how their generic name ends. What does it specifically end with? With ACE inhibitors, the generics are going to end with pril, like lisinopril. With ARBs, the generics will end with sartan, like losartan. So when you're looking at the meds and you're trying to determine, is this an ACE or an ARB, look at the ending of those generic names. It'll really help you. And another thing I want to point out is with ACE inhibitors, some patients, not all, can develop this persistent, nagging, dry cough. And the reason for that is because of how this ACE inhibitor is influencing this ACE enzyme that is converting angiotensin 1 into angiotensin 2. Over here with ARBs, a dry, persistent, nagging cough is not likely. And a lot of times, if a patient does develop this dry, persistent cough with an ACE, the physician may put them on an ARB because that will help clear that up. So the reason for that is because ACE normally will inactivate a substance called bradykinin. Bradykinin is an inflammatory substance, and what it will do is it will break it down so it will inactivate it. But if we're blocking this by throwing on an ACE inhibitor, we're not going to be inactivating this bradykinin. So it can increase and it can cause this coughing. Another thing with ACE inhibitors that you want to watch out for as the nurse is something that can happen called angioedema. This is where you have swelling of the deep tissues, and it can present of swelling of the face, the tongue, the lips, and it can cause difficulty breathing. And if that happens, that's a medical emergency. It's less likely to happen with an ARB, so there's a low chance of it happening, but you always just want to monitor for that as well. Now let's wrap up this review and let's talk about what these medications are used for and look at our nursing interventions and our patient education together. So what are ACE and ARBs used to treat? Well, we've already learned that they help lower the blood pressure. So they're great in helping patients who have hypertension, managing that blood pressure, keeping it low. In addition, patients who have heart failure. This is where that heart muscle is damaged and it can't really pump, so it's not really maintaining cardiac output. Plus, blood can backflow, go into the lungs, lead to pulmonary edema. And how ACE and ARBs will work is that they can help decrease the afterload and the preload on the heart, making it easier to pump and get blood out to maintain cardiac output. In addition, ACE and ARBs can be used after a patient has a myocardial infarction. Again, just helping the heart pump easier after it's been damaged. And these medications can help decrease the progression of diabetic nephropathy in those patients who have type 2 diabetes. Now, what is diabetic nephropathy? Well, this is kidney disease caused by diabetes. And whenever a patient has kidney disease, those little nephrons in the kidneys are affected because that's a functional unit of the kidney that does the work. And they really lose the ability to filter the blood very well. So protein will start to leak into the urine. Well, if you have high blood pressure, you're increasing the amount of protein that's going into the urine. Well, if we throw an ACE and ARB on, that can help lower the blood pressure, which will decrease the amount of protein that's going into the urine, hence slowing down our kidney disease. So these medications have like that renal protective mechanism. Now, what are some patient education and things you want to watch out for as the nurse? Well, we've learned that these medications can increase the potassium level with the way that it affects aldosterone, because aldosterone is not really going to be released. So now the kidneys are going to start keeping potassium. So there's a risk for hyperkalemia. Therefore, you want to monitor the potassium levels, but you want to tell the patient to avoid consuming a diet really high in potassium. So watch those salt substitutes that have potassium and those foods that are high in potassium, like spinach, avocados, bananas, etc., because that can increase our potassium levels. In addition, you want to talk to the patient about how to prevent a condition called rebound hypertension. This is where the blood pressure will get so high, it'll be hard to actually bring the blood pressure down. And this tends to happen when a patient just abruptly quits taking their ACE or their ARB. So educate the patient about the importance of never just quit taking the medication, because sometimes a patient, let's say they're started on an ACE inhibitor, they develop that dry, nagging, persistent cough. It's driving them crazy, and it's driving everyone else around them crazy because they keep coughing. So they may just quit taking the medication. But instead of doing that, they need to talk to their doctor, and their doctor could switch them to something else where they won't have that dry cough. So just let them know that that can happen if they just abruptly quit taking it. In addition, they need to make sure they're monitoring their blood pressure at home. They need to get a device. They need to write down the recordings of what their blood pressure is. Daily doing this is best, because we want to make sure that these medications are in fact managing their blood pressure, or are they still hypertensive, or is it too much? They're hypotensive. So definitely communicate that to them. And lifestyle changes that they need to do. If they're taking these medications to help lower the blood pressure, let them know that antihypertensive medications are not a cure for high blood pressure. They need to manage their diet by eating healthy, exercising, or quit smoking if they're smoking to help with that as well. So we want to monitor the potassium level as we discussed over here because of hyperkalemia, but we also want to look at the liver enzymes, making sure the liver is not being affected, and renal function. Because in some patients who are dependent on the RAS, because let's say they have severe heart failure. With severe heart failure, their cardiac output isn't that great. So they depend on this RAS to maintain cardiac output for them. So if we give them an ACE and an ARB, which affects RAS, that's really going to cause some kidney issues. So we want to be making sure we monitor the BUN, the creatinine. What's their urinary output? Is it at least 30 cc's an hour? Are they having any abnormal swelling going on in their body where they're retaining fluid? And lastly, you want to talk to the patient about this cough that can happen with these ACE inhibitors. And if they can't tolerate it, what should they do? And remember, they can be switched to ARBs, which doesn't have that dry, persistent cough. Now, one thing you really want to watch out for if you're working with patients who have heart failure and they're on an ACE inhibitor, let's say that all of a sudden they get this cough. Well, you want to further investigate this cough. You don't want to just write it off, oh, it's that cough that you get with ACE inhibitors, because with heart failure, their heart will be weak, the blood will back up into the lungs where they'll get pulmonary edema, so they'll start getting a cough. But this cough will be like a wet cough. You'll hear crackles if you listen to their lungs. They'll have difficulty breathing with just any movement, like moving from the bedside chair to the bed. They get really winded. So you want to make sure that, is this just that cough that you get with ACE inhibitors, which is dry, it's not going to have crackles or wet, or is this heart failure exacerbation? So make sure you look at that. In addition, educate the patient about this angioedema. That's more likely to happen with the ACE inhibitors, but it can happen with ARBs. It's less likely, it's rare too, but educate them about the swelling of the face, the mouth, the lips, difficulty breathing, and let them know that's a medical emergency and that they should seek attention immediately. Okay, so that wraps up this review over ACE inhibitors versus ARBs. Thank you so much for watching. Don't forget to take the free quiz and to subscribe to our channel for more videos.
and hypotension. So calcium channel blockers inhibit the movement of extracellular calcium ions into cells. The inhibition of calcium ion influx produces vasodilation, which produces coronary vasodilation and reverse vasospasms. This reduces the afterload on the heart. So calcium channel blockers are used in the treatment of both angina pectoris and hypertension. With the calcium channel blockers, vascular smooth muscles relax, and dilation of coronary and peripheral arteries and arterioles occur, reducing preload. The effect of the calcium channel blockers on the heart may reduce its rate, decrease myocardial contractility, and slow the AV nodal conduction. Most side effects associated with the calcium channel blockers are extensions of their pharmacologic effects. They can produce excessive hypotension, which can cause dizziness and lightheadedness. Dental patients should be warned to rise from the dental chair slowly. Headache can then occur. Gastrointestinal side effects include nausea, vomiting, and constipation. Because they have a depressant effect on the heart, bradycardia and edema can result. Flushing as a result of vasodilation should not be confused with an allergic or adverse reaction. Peripheral edema has been reported. Shortness of breath as a result of pulmonary edema has been reported, and nasal congestion and rhinitis may interfere with the administration of nitrous oxide and oxygen for analgesia and anxiety relief. So the oral manifestation of the calcium channel blockers include the xerostomia, dysgeusia, and gingival enlargement. So like the phenytoin enlargement, nifedipine enlargement begins as nodular and firm tissues that bleed easily on probing. The enlargement begins in the anterior labial dental papillae and can proceed eventually to include the lingual and palatal gingiva. Detailed oral hygiene instructions and more frequent recall appointments to reduce plaque load have been said to reduce this enlargement. On discontinuation of the calcium channel blocker or switching to a drug outside of that group, the gingival enlargement usually reverts to normal tissue and does not reappear. So calcium channel blockers are one of the few antihypertensive groups whose effect is not reduced by the NSAIDs. Beta-adrenergic blockers are frequently used to treat hypertension. The beta-1 receptor stimulation is associated with increased heart rate, cardiac contractility, and AV conduction. The beta-2 receptor stimulation causes vasodilation of skeletal muscle and bronchodilation in pulmonary tissue. So the beta-adrenergic blockers lower blood pressure by decreasing cardiac output. Beta-adrenergic blockers inhibit these actions. They may also lower the plasma renin levels, reduce plasma volume and venous return, decrease sympathetic outflow from the CNS, and reduce peripheral resistance. These agents are usually recommended for treating hypertension in patients that also have heart failure, post-myocardial infarction, angina, or suffer from migraine headaches. Studies have found that they are less effective than the ACE inhibitors, the ARBs, and calcium channel blockers in preventing cardiovascular events such as stroke. They are less effective in Black patients. So the beta-adrenergic blockers lower blood pressure by decreasing cardiac output. Side effects of the beta-adrenergic blockers include bradycardia, mental depression, decreased sexual ability, heart failure, and CNS effects such as confusion, hallucination, dizziness, and fatigue have also been reported. GI tract effects including diarrhea, nausea, and vomiting. So beta-adrenergic blockers can also produce xerostomia or worsen a patient's lipid profile. They may exacerbate asthma, angina, or peripheral vascular disease. So non-selective beta blockers can have a drug interaction with epinephrine. Patients pre-treated with a nonspecific beta blocker such as propranolol and given epinephrine may have a 2 to 4-fold increase in vasopressor response, resulting in hypertension. In patients with cardiovascular disease or higher blood pressure, the amount of epinephrine given to patients taking nonspecific beta blockers should be limited to the cardiac dose unless blood pressure monitoring accompanies the use of the larger doses. Neither gingival retraction cord containing the epi nor the 1 to 50,000 epinephrine should ever be used. Usual doses can be given to patients taking specific beta blockers or alpha and beta blockers. So labetalol is a non-selective beta adrenergic receptor blocking drug that also has an alpha receptor blocking activity. In addition to the typical beta adrenoceptor blocking effects, labetalol also reduces the peripheral resistance throughout its alpha blocking actions. The side effects of labetalol are similar to that of the alpha and beta adrenergic blocking drugs. Doxazosin or Cardura and terazosin, which is Hytrin, are examples of selective alpha-1 adrenergic blocking drugs. The alpha-1 receptors located on the postsynaptic receptor tissues produce vasoconstriction and increase peripheral resistance when stimulated. The blocking agents produce peripheral vasodilation in the arterioles and venules that decreases peripheral vascular resistance. These agents have little effect on cardiac output or renal blood flow. They are more effective when combined with diuretics or beta blockers. These agents are used in the management of older males who have an enlarged prostate gland. Adverse reactions include orthostatic hypotension, CNS depression, and cardiovascular effects such as tachycardia, arrhythmias, and palpitations. Peripheral edema may then occur. NSAIDs can reduce the antihypertensive effect of the alpha blockers, and epinephrine can increase the antihypertensive effect of doxazosin. These other antihypertensive agents are used less often because they generally have more or less tolerated adverse reactions. Clonidine. You need to know about clonidine. It reduces peripheral resistance through a CNS-mediated action on the alpha receptor. Thus, clonidine reduces heart rate, cardiac output, and total peripheral resistance. It is indicated for the management of essential hypertension. Adverse effects of clonidine include a high incidence of sedation and dizziness and possibly a rapid elevation of blood pressure. Clonidine oral effects include xerostomia, parotid gland swelling, and pain. Dysgeusia is another side effect. Methyl-dopa is another centrally acting antihypertensive drug with adverse effects similar to clonidine. This drug may be combined with diuretics in essential hypertension management. Hydralazine exerts its antihypertensive effect by acting directly on the arterioles to reduce peripheral resistance. At the same time, a rise in the heart rate and output occurs. Propranolol is often administered concurrently to reduce the reflex tachycardia and increase cardiac output. Hydralazine is often used in combination with the thiazides or other antihypertensive agents. So the most commonly reported side effects include cardiac arrhythmias, angina, headache, and dizziness. A serious toxic reaction produces symptoms like those of systemic lupus erythematosus. Reserpine was originally used as a tranquilizer. It is currently used in a low dose as an antihypertensive agent. It depletes norepinephrine from the sympathetic nerve endings and can accumulate in the body. Adverse reactions include diarrhea, bad dreams, sedation, and even psychic depression leading to suicide. It increases the production of stomach acid and aggravates peptic ulcers. It can produce galactorrhea, breast engorgement, and gynecomastia. So because the hypertension of patients taking antihypertensive medications may or may not be controlled, the blood pressure of each patient has to be measured on each visit to the dental office. This doesn't stop when you guys graduate from dental hygiene school. So adverse reactions include xerostomia, dysgeusia, gingival enlargement, orthostatic hypotension, constipation, and or CNS sedation. Okay, so this slide and the next is just your learning objectives for the section 12.2, cardiovascular agents. Heart failure. So the incidence of course of heart failure rises with age. The heart functions as a pump. It ensures adequate circulation of the blood to meet the oxygen needs of all the body tissues. If the heart is unable to keep up with the body's needs, it becomes a failing heart and the pumping mechanism becomes inefficient. This inefficient pumping mechanism results in an inadequate cardiac output and unsatisfactory circulation. Various forms of injury to the heart, such as a heart attack, arrhythmias, and valvular abnormalities from rheumatic heart disease, can contribute to a failing heart. So the heart has two sides. In heart failure, blood accumulates in the failing ventricle. The ventricle enlarges and finally becomes ineffective as a pump. One or both sides of the heart can fail. Usually the left side fails first. Left side failure backs into the pulmonary circulation, the lungs, leading to edema, dyspnea, and orthopnea. Dental patients with a left failure may need to have dental treatment performed with the patient in a semi-reclined position. You need to know that. The right side heart failure causes systemic congestion, leading to peripheral edema with fluid accumulation evidenced by pitting edema. So I have just a picture here of the autonomic nervous system. I love how this is just broken down for easy reference. The autonomic nervous system receptors act as an on and off button that actually control the various sympathetic and parasympathetic effects in the body. So when these buttons are turned on or off, things happen. If you learn about these receptors and their actions, you will be able to understand more about what a beta blocker drug does or what to expect from an alpha agonist medication. So I just wanted to introduce that to you. Diuretics. So for heart failure treatment, diuretics are at the top of the list. They're used in patients with heart failure to relieve the symptoms of edema or fluid retention. Aldosterone antagonists are recommended for patients with specific ventricular ejection fraction, especially if the patient also has a history of diabetes. Vasodilators reduce the peripheral resistance by arterial vasodilation. This reduces the work of the heart. The most common digitalis glycosides is digoxin. The brand name is Lanoxin. So the major effect of digoxin on the failing heart is to increase the force and strength of contraction of the myocardium. It allows the heart to do more work without increasing its oxygen use. Digoxin also reduces the edema that occurs with heart failure. As a result of the improved pumping action, more blood circulates through the kidneys, which mobilizes the edema from the tissues, producing diuresis. The diuresis is not a result of an effect on the kidneys. It is a result of digoxin's indirect effect produced by the improving heart's function. Digoxin is used in the treatment of heart failure and for atrial arrhythmias, including atrial fibrillation and paroxysmal atrial tachycardia. Digoxin actually prolongs the refractory period of the atrioventricular node. You need to know that. The AV node. So because of digoxin's narrow therapeutic index, toxic effects are not uncommon. Even slight changes in dose, absorption, or metabolism can trigger toxic symptoms, especially in the elderly population. Early signs of digoxin toxicity include anorexia, nausea and vomiting, and copious salivation. If a sufficient overdose is given, severe cardiac irregularities can develop and progress to ventricular fibrillation and death. Also, the diuretics used to treat heart failure can produce hypokalemia, which can predispose a patient to serious arrhythmias, and digitalis is used to treat arrhythmias, and its toxicity can produce arrhythmias. The neurologic signs of toxicity include headache, drowsiness, and visual disturbances. Other effects reported include a pain in the lower face resembling that of trigeminal neuralgia, weakness, faintness, and mental confusion. Increased salivation and increase in the gagging reflex are associated with digoxin toxicity. You need to know that one. You're going to watch for overdose side effects such as nausea, vision changes, and copious salivation. Use epinephrine with caution to minimize arrhythmias. Monitor the pulse to check for normal rate and irregular rhythm. An abnormally slow rate or irregular rhythm should be reported to the patient's provider for evaluation. So tetracycline and erythromycin can increase digoxin levels in approximately 10% of the patients. So angina pectoris is a common cardiovascular disease characterized by pain or discomfort in the chest, radiating to the left arm and shoulder. Pain can also radiate to neck, back, and lower jaw. Jaw pain may be confused with a toothache. Angina occurs when coronary arteries do not supply enough oxygen to the myocardium for its current work. It can be precipitated by the stress induced by physical exercise or emotional states such as anxiety and apprehension generated by a dental appointment. So nitroglycerin-like compounds. So you need to know this slide. Nitroglycerin, nitrostat, or nitrolingual is by far the most often used nitrate for management of acute anginal episodes. It is also used to prevent anginal attacks induced by stress or exercise. So nitroglycerin is a vasodilator that produces relaxation of vascular smooth muscles throughout the body. Nitroglycerin causes venous dilation, which reduces the amount of blood returning to the heart, thereby reducing the heart's workload. The arterial dilation reduces the resistance against which the heart must pump. By reducing workload on the heart, nitroglycerin decreases the oxygen demand. Sublingual nitroglycerin is used to treat acute anginal attacks. It has a rapid onset by this route and its effect can last up to 30 minutes. Sublingual isosorbide dinitrate is also effective for an acute anginal attack. So, adverse reactions. Okay, so nitroglycerin is a vasodilator that produces relaxation of vascular smooth muscle. Most adverse reactions associated with this occur because of its effect on vascular smooth muscle. Severe headaches are often reported. Flushing, hypotension, lightheadedness, and syncope can also result. Sublingual nitroglycerin can produce a localized burning or tingling at the site of administration. Phosphodiesterase 5. These are also known as the PDE5 inhibitors, which I will refer to them as we continue along. They are a class of drug used to treat erectile dysfunction. So these drugs include sildenafil, which is also the generic name for Viagra, vardenafil, which is Levitra, and tadalafil, which is Cialis. Cialis. So you need to know that the administration of any of these drugs with doses of any nitrate is contraindicated. The combination can cause dangerously low blood pressure. Beta-adrenergic blocking agents are used in the treatment of angina as well as hypertension. So these drugs block the beta response to catecholamine stimulation. This reduces both the chronotropic and inotropic effect. The net result is a reduced myocardial oxygen demand. The beta-adrenergic blocking agents are effective in reducing both exercise and stress-induced anginal episodes. They are also recommended to help prevent myocardial infarction and death in patients with documented coronary artery disease. Adverse effects include bradycardia, congestive heart failure, headache, dry mouth, blurred vision, and unpleasant dreams. So just as a reminder, adrenergic drug, any of various drugs that mimic or interfere with the functioning of the sympathetic nervous system by affecting the release or action of norepinephrine and epinephrine. Adrenergic drugs that produce or inhibit these effects are known as sympathomimetic agents and sympatholytic agents, respectively. Okay, calcium channel blocking agents. You really need to know about these. They do appear on board. They are used as initial therapy when beta blockers are contraindicated or their side effects are just intolerable. Adverse effects include dizziness, weakness, constipation, and hypotension. Nifedipine. You need to know about nifedipine. You may see this on a case study when you take your exams, your national boards. You'll probably see something about nifedipine on the test. It's associated with gingival enlargement and dysgeusia. When calcium channel blockers are used, in addition to high blood pressure, doctors prescribe calcium channel blockers to prevent, treat, or improve symptoms in a variety of conditions such as coronary artery disease, chest pain, irregular heartbeat, well, chest pain, angina, irregular heartbeats, and some circulatory conditions such as Raynaud's disease. For Black people and older people, calcium channel blockers might work better than other blood pressure medications, such as beta blockers, angiotensin converting enzyme inhibitors, or angiotensin II receptor blockers. Ranolazine is indicated for the treatment of chronic angina or in combination with nitrates, beta blockers, calcium channel blockers, antiplatelet therapy, lipid-lowering therapy, ACE inhibitors, or the ARBs. It can be used alone in patients with contraindications to beta blockers and calcium channel blockers. Its exact mechanism of action is unknown, and it does not significantly alter heart rate or blood pressure. That can reduce the incidence of ischemia. Angiotensin receptor blockers, the ARBs, are indicated for those patients with chronic stable angina that also have hypertension, diabetes, or again the LVEF of less than 40%, and chronic kidney disease that cannot tolerate the ACE inhibitors. Angiotensin II is a very potent chemical formed in the blood that causes muscles surrounding blood vessels to contract, thereby narrowing the vessels. This narrowing increases the pressure within the vessels that can cause high blood pressure. So angiotensin II receptor blockers, the ARBs, are medications that actually block the action of angiotensin II by preventing angiotensin II from binding to angiotensin II receptors on the muscles surrounding the blood vessels. As a result, blood vessels enlarge, so they get bigger, and blood pressure is reduced. Reduced blood pressure makes it easier for the heart to pump blood and then can improve heart failure. In addition, the progression of kidney disease caused by the high blood pressure or diabetes is then slowed. ARBs have effects that are similar to the angiotensin converting enzyme, the ACE inhibitors, but ACE inhibitors act by preventing the formation of angiotensin II rather than by blocking the binding of angiotensin II to muscles on blood vessels. If that's overwhelming for you, I know it's not in your book, but I wanted an explanation. You aren't going to be tested on it, but maybe it'll help connect some dots. Okay, so we need to be prepared to treat an acute anginal attack before treating the patient with a history of angina. So before administering nitroglycerin, the dental team should make sure that that patient has not used a drug for erectile dysfunction within the past 24 hours. Two methods to prevent an acute attack of angina include pre-treatment with an anxiolytic agent such as benzodiazepine or nitrous oxide or sublingual nitroglycerin. You need to know that a patient with symptoms of an anginal attack that is not relieved by 3 doses of the sublingual nitroglycerin may be experiencing a myocardial infarction. Treatment by an emergency team is required, and occasionally an anginal attack can proceed to an acute myocardial infarction. With that said, in any situation in the clinic, when there is an emergency coming up, you will disturb any instructor, no matter what they're doing, to let them know what is going on. You can have a neighbor if you need to stay quiet, keep the commotion down and calm. You can tell your next door neighbor, the other student, to get an instructor. At any rate, an instructor must be called. But you need to know how to treat it, because it would be much easier if everybody's on the same page. It would go much more smoothly. So when you administer, first of all, because they had nitroglycerin, you would have had them have it out. It's okay if they have it in an easy to reach pocket on themselves. We prefer to keep it on the computer card. But if it's not possible, or you are afraid they'll forget it, or maybe the patient doesn't want to take it out, have them put it in an easy to reach location. So if the patient has an episode of angina and is suffering from pain, they're going to recognize it. And that's another point. The only way we will know that the patient has angina, or the possibility of their pain is angina, is because they've been diagnosed with it. Their doctor, they've already had an episode, and their physician already knows that they suffer from angina. We're not going to be the first experience that they have of it. But that's why it's so important to update a medical history before they come in and hit all of the questions, so we don't have surprise scenarios when they come in. So we have the nitroglycerin in reach. We can help the patient open the bottle. We can help them take the medication. We're not actually administering it. They are still able to function, and they'll take it themselves. It's like taking an aspirin or an NSAID. So they'll take the medication. We wait 2 to 4 minutes. If the pain does not subside, we'll help them with the second one. Now, our clinic manual, after the second one, if it doesn't subside in 2 to 3 minutes, we are enacting the emergency sequence of events. So, and we will go ahead and administer the third one, but the 911 has already been called. So you just need to keep that in mind. And again, an instructor is there. You won't be doing it alone, and the instructor will help guide you as far as handling this situation. Again, nitroglycerin, the patient should bring in. Another thing, the first one we give the patient out of his pocket, whatever the patient had brought in. The second pill we actually take from our emergency kit, because just in case, because nitroglycerin pills are very sensitive, and once they're open, they're expired after 6 months of being opened, even if they're sealed tightly. So with that known, it's possible maybe there was an air leak, even if the patient thinks that that bottle was unopened. Maybe it's possible it had been exposed and it's no good anymore. So the second one, the second dose, we will go grab that nitroglycerin tablet from our emergency kit. We know that that's fresh. We keep it up to date, and it's not opened. So we will give it to them, and hopefully that will ease the pain that they're suffering from. But at any rate, that is what you need to know about treating an acute anginal attack. So the terms arrhythmia and dysrhythmia are used interchangeably to mean abnormal rhythm. Arrhythmias may result from abnormal impulse generation or abnormal impulse conduction. Cardiac diseases such as myocardial anorexia, arteriosclerosis, and heart block can produce arrhythmias. So cells of cardiac muscles have an intrinsic rhythm called automaticity. Pacemaker cells spontaneously produce action potentials as they undergo slow spontaneous depolarization during diastole. If any heart muscle cell is left undisturbed and isolated from the rest of the heart with appropriate nutrients and oxygen, each cell will beat spontaneously at its own rate. Each type of cardiac cell differs in its automaticity depending on the function of the particular cell. The cells that specialize in conduction functions have a faster rate of automaticity than other cardiac cells. This design ensures that the heart will beat in a coordinated manner. With normal heart function, the sinoatrial, the SA node in the right atrium has the fastest rate of depolarization and directs other cells of the heart. It is innervated by both the parasympathetic and sympathetic nervous system. You need to know that it signals the atrioventricular, the AV node, which sends signals through the bundle of His to Purkinje fibers. The Purkinje fibers then send the message to the cardiac muscle cells to the apex of the ventricles, directing them all to contract as they get the message. In the normal patient, this system functions seamlessly with each heartbeat. In the patient with cardiac arrhythmias, diseased parts of the heart can produce abnormal conduction pathways, which then result in arrhythmias. So arrhythmias are divided into supraventricular atrial and ventricular types, depending on the genesis of the arrhythmias. Anti-arrhythmic agents are placed into 4 different groups. So you can review this table here. They may decrease the velocity of depolarization, decrease impulse propagation, and inhibit aberrant impulse propagation. And we'll get into each of these. For all patients taking any antiarrhythmic agents, check for abnormal or extra beats when taking the patient's blood pressure and pulse. Record the type of arrhythmia and the drug therapy. Patients taking warfarin for atrial fibrillation should have their international normalized ratio checked, and you need that number in order to treat them. Amiodarone is an antiarrhythmic agent used to treat atrial fibrillation or ventricular tachycardia. Patients may exhibit liver toxicity, blue skin discoloration, or photosensitivity to the dental light. So you see here in bold, calcium channel blockers and phenytoin may contribute to gingival enlargement. Disopyramide can cause xerostomia. Procainamide can cause reversible lupus erythematosus like syndrome, CNS depression, and xerostomia. Quinidine can cause nausea, vomiting, diarrhea, synchronism with large doses, and the atropine-like effect of xerostomia. Beta blockers, nonspecific, can cause a drug interaction with epinephrine. Antiarrhythmic agents have a narrow therapeutic index and are difficult to manage. These agents are only used for patients with arrhythmias that prevent the proper functioning of the heart. Okay, now we're going into the next section, antihyperlipidemic and blood coagulation agents that alter dental treatments. So we're going to start with the antihyperlipidemia. And hyperlipoproteinemia are elevations of plasma lipid concentrations above accepted normal values. These metabolic distortions include elevations in cholesterol and or triglycerides and are associated with the development of arterial sclerosis. So the newest guidelines from the ACC and AHA no longer recommend using specific cholesterol targets for deciding treatment for patients with elevated cholesterol levels. The focus is now on the patient's estimated 10-year atherosclerotic cardiovascular disease risks. Lifestyle modifications, including adhering to a heart-healthy diet, regular exercise, avoiding tobacco products, and maintaining a healthy weight, remains a critical component of lowering lipid levels. So the HMG-CoA reductase inhibitors, the statins, are the drugs of first choice for treating patients with atherosclerotic and cardiovascular disease. So this is the 3-hydroxy-3-methylglutarol coenzyme A reductase inhibitors, the HMG-CoAs. So a reductase inhibitor the statins are the first choice of therapy for patients with atherosclerotic heart disease and elevated cholesterol. Lovastatin, Mevacor, is an example. You'll see that a lot in clinic. The statins lower cholesterol levels by inhibiting the HMG-CoA reductase and the rate-limiting enzyme in cholesterol synthesis. The adverse effects of the HMG-CoA reductase inhibitors include gastrointestinal complaints such as stomach ache, constipation, diarrhea, and gas. Other side effects are myositis, skin rash, impotence, hepatotoxicity, blurred vision, and lens opacities. Myositis results in complaints of muscle pain. These agents can increase anticoagulant effects of warfarin. Ezetimibe works by inhibiting intestinal absorption of cholesterol. It currently comes in combinations with simvastatin or atorvastatin to treat cholesterol from two different mechanisms of action. Ezetimibe decreases total cholesterol, the LDL, and increases the HDL-C levels. The fixed dose combination lowers the LDL-C levels more than a statin alone. Side effects include fatigue, abdominal pain, and diarrhea. So we're going to talk a little bit about this vitamin B3, niacin. In large doses, niacin actually lowers cholesterol levels by inhibiting the secretion of the very low density lipoproteins without accumulation of triglycerides in the liver. This reduces the LDL synthesis. At these larger doses, niacin commonly produces cutaneous flushing and a sensation of warmth after each dose. This reaction can be blocked by pretreatment with either aspirin or ibuprofen. The reaction can be minimized by beginning with a low dose of niacin and slowly increasing the dose over a period of weeks or by taking it after meals. Hyperuricemia, allergic reactions, cholestasis, and hepatotoxicity have been reported. Hypotension may occur in dental patients when rising from a dental chair. The bile acid binding resins cholestyramine and cholestepols lower cholesterol concentration because cholesterol is a precursor that's required for the synthesis of the new bile acids. When the resins bind with bile acids, they produce an insoluble product lost through the GI tract. Bile acids use up cholesterol, thereby reducing cholesterol levels. Adverse reactions include constipation and bloating, but serious side effects are infrequent. The drugs are poorly tolerated because of these effects and poor taste. The fibric acid derivatives are used to treat hyperlipidemias, especially when triglycerides are elevated. These drugs causes fewer GI complaints than the bile acid binding drugs, but can promote gallstone formation. Other adverse reactions include an altered sense of taste and hyperglycemia. These drugs should not be given with statins because of the increased risk for muscle cramping, myopathy, and rhabdomyolysis. Fish oils, long-chain omega-3 polyunsaturated fatty acids, or PUFAs, are present in cold water fish and are commercially available in capsules to treat elevated cholesterol levels. They can decrease fasting triglyceride concentrations by reducing hepatic triglyceride production and increasing triglyceride clearance. Adverse effects include belching, unpleasant fishy aftertaste, and worsening of glycemic control in diabetic patients. Patients who take anti-hyperlipidemic agents have a higher risk for developing hypertension and coronary artery disease. These patients are at an increased risk for myocardial infarctions and cardiac arrest. Dental health care workers should be prepared to handle such emergencies. The patient's blood pressure and pulse rate should be taken before each appointment and recorded in the dental chart. Because GI and liver abnormalities are side effects associated with many of these drugs, their tolerance to the agent should be determined before dental drugs are prescribed or suggested. The small possibility of liver abnormalities requires laboratory testing for abnormal liver function. Anticoagulants. Need to know about this. Drugs that interfere with coagulation are called anticoagulants. Warfarin or Coumadin is the most important oral anticoagulant, and it is used almost exclusively in anticoagulant therapy. Warfarin is an oral anticoagulant that blocks the GABA carboxylation of glutamate residues in the synthesis of factors 7, 9, and 10. Prothrombin 2, an endogenous anticoagulant protein C. It also prevents the metabolism of the inactive vitamin K epoxide back to its active form. That's just an overview. You are not going to be tested on that section. You do need to know about warfarin. It was just that last slide. Adverse reactions associated with the oral anticoagulants are various forms of bleeding, including hemorrhage. Because of its narrow therapeutic index and numerous drug interactions, serious reactions can easily occur. One should look for petechial hemorrhages in the oral cavity. Ecchymosis can occur even without trauma. And this picture, I think, is a great diagram of what we're looking at. You can see the ecchymosis is just like a larger bruise. Who need analgesics may require more frequent monitoring of the INR. Antibiotics can also potentiate the effect of warfarin. If an antibiotic is to be used with warfarin, clindamycin has no effect. Doxycycline, tetracycline, and amoxicillin have small effect, and erythromycin and metronidazole have the greatest effect on altering warfarin's anticoagulant action. Phenobarbital induces the liver microsomal enzymes that reduce warfarin's effect. With chronic alcohol ingestion, the metabolism of warfarin is stimulated. Acute alcohol intoxication inhibits metabolism of warfarin. Other agents that inhibit the metabolism of warfarin include cimetidine, disulfiram, and metronidazole. Heparin. So heparin, this is one of the most commonly used anticoagulant agents for hospitalized patients because it must be administered by injection and it is not used orally. Heparin is indicated for use after a myocardial infarction, a stroke, or a thrombophlebitis. When heparin is started, warfarin is also begun. Heparin provides immediate anticoagulant effect while the effect of warfarin is building up. An overdose of heparin is antagonized by protamine sulfate, which immediately reverses its anticoagulant effects. So you need to know that a danger of embolism exists if the dose of the anticoagulant is too small. So rivaroxaban and apixaban are factor XA inhibitors that prevent coagulation by selectively blocking the active site of factors XA and does not require a cofactor of activity. Both drugs are indicated to reduce the risk of stroke and systemic embolism in patients with non-valvular atrial fibrillation. Rivaroxaban is also indicated for the treatment of deep vein thrombosis and pulmonary embolism and for the reduction in the risk of recurrence of both. So Dabigatran or Pradaxa is a direct thrombin inhibitor which is indicated for the prevention of stroke and systemic embolism in patients with non-valvular atrial fibrillation. This drug directly prevents the clot from forming. The most common side effect are GI and increased risk for bleeding. Clopidogrel, Plavix, is an inhibitor of adenosine bisphosphate, ADP, induced platelet aggregation, which results in prolonged bleeding time. It's indicated for patients with recent history of a myocardial infarction or stroke, established peripheral arterial disease, and for patients with acute coronary artery syndrome. Its major side effect includes thrombotic thrombocytopenia purpura and increased bleeding. Ticlopidine or Ticlid is an irreversible inhibitor of ADP-induced platelet aggregation, which results in increased bleeding time. It is indicated to decrease thrombotic stroke in patients with previous stroke, and it is used in patients who are intolerant of aspirin. Its major side effect is neutropenia. So this is an additional slide, and I have added it in here. I need to be able to move my finger. Doesn't matter. Anyway, prasugrel and ticagrelor. So both of these are newer medications. So let's start with prasugrel, what you need to know about it. It's used in conjunction with aspirin. It's used for the prevention of a myocardial infarction and a stent thrombosis in persons with acute coronary syndrome undergoing percutaneous coronary intervention. It's contraindicated in persons with a history of stroke or transient ischemic attack. The risk for bleeding is greater in older persons. Ticagrelor. This is a platelet aggregation inhibitor, and it is used in conjunction with aspirin for the prevention of a myocardial infarction and stroke in persons with acute coronary syndrome. The most common side effects include shortness of breath and bleeding. Streptokinase. Alteplase are sometimes used in the therapy of deep vein thrombosis, arterial thrombosis, pulmonary embolism, and acute coronary artery thrombosis associated with MI. They are called thrombolytic drugs because they promote conversion of plasminogen or plasmin, the natural clot resolving enzyme. So you do need to know about dipyridamole. It is used to prolong the life of platelets in patients with prosthetic heart valves. The artificial valves cause premature death of platelets due to their mechanical effect or trauma on blood cells passing through the valves. So pentoxephyllin. This improves blood flow by its hemorrhagic effect. It lowers blood viscosity and improves flexibility of red blood cells. It's indicated for claudication or limping produced by the chronic occlusive artery disease of the limbs. Side effects include cardiovascular and gastric symptoms. Dry mouth, bad taste, excessive salivation, and swollen neck glands have infrequently been reported. Aminocaproic acid and tranexamic acid are similar to the amino acid lysine. They inhibit plasminogen activation. They are used in the treatment of hemorrhage after surgery. Adverse effects include intravascular thrombosis, hypotension, and abdominal discomfort. So that is it. This was a long one, chapter 12. I hope you hung in there with me.